This year I decided to present 3 papers to give us a glimpse of where transplant is going for the future. So the first one was Orca-T and the randomized phase 3 study of Orca-T against standard of care with methotrexate. So for those who don't know, when we usually give transplants, we give the stem cell back of the donor that collected, and we just give it, and we just hope it works. But what Orca-T is a graft engineering, meaning that we send it back to the manufacturing facility, and then they divide the components of this lovely bag into hematopoietic stem cells, Tregs, and T conventional cells. And when the patients get the cells back, they're giving at a specific ratio so that you actually know a little bit more what's going into the transplant. So they get the hematopoietic stem cells on day 0, along with the T regulatory cells. And those T regulatory cells go into the lymph nodes and they start expanding. So by the time the conventional cells come on day +2, the environment's already better for them to start acting. We want those T cells to have the graft versus leukemia effect, but the T conventional cells that are going to develop into graft versus host disease, we want them to be regulated with the T regulatory cells. So this phase 3 study was just published, was just presented last year in the EBMT 2025, and it met its primary outcome that was survival free of moderate to severe chronic GvHD. And this is very exciting because it's showing us that with this graft engineering and only single agent tacrolimus, we can have improved chronic graft versus host disease for our patients. And then on the outcomes that they presented, they didn't seem to have worse immune reconstitution. And what do I mean with that? Well, we want to prevent graft versus host disease, but at the same time, we want to make sure that the new T cells that these patients develop work. And then by fighting infections, for example. So when they actually compare the rate of infections, it was not worse than methotrexate. And we're going to see the follow-up outcomes as the trial progresses. So that was the first study. It's more like, how can we design a better graft versus host disease prophylaxis? The second study I presented was the companion study for BMT-CTN 1703, which is 1801. So people know about 1703 because that's the PTCy win. So it was PTCy against methotrexate for reduced intensity conditioning. And this was presented, and everyone loves PTCy, and PTCy is now the standard care for post-transplant for reduced intensity conditioning. However, this companion study, they co-enroll patients so that they can provide samples along their transplants, and also the donors and the patients. And it's intended to provide immune reconstitution data. So the patients, like over 400 patients were enrolled in the 1703, and the 1801, they had co-enroll around 350 patients. They had tons and tons of samples for sequencing. And what they want to sequence is how is the immune reconstitution of these patients. And what they found now was that with the PTCy compared with the methotrexate, there is like a bottleneck effect, meaning patients or like normal people have tons of T cells that are very, very diverse, and they're against like pathogens like EBV, viruses, and like all the things that they protect us from. When we give PTCy, the T cell diversity decreases significantly, but when it starts to expand, the TCR, like the T cell diversity, it's very decreased up to 2 years after transplant. So compared to methotrexate. And what does that mean? Well, PTCy is a great agent to do pan T cell depletion. And that involves killing the TCRs, like the T cells that are against the graft. But it's also killing the T cells that are defending us from infections. When they actually look at the T cells that are assessing the immunophenotype of those T cells, like against EBV, like HEV6, all these viruses, they did sequencing to detect this clonotype of these T cells. And they showed that the patients that have PTCy have much lower TCR diversity against those viruses and infections compared to PTCy. So what does that show us? Well, we still have a long way to go in terms of defining what's the best graft versus host disease prophylaxis so that we can decrease graft versus host disease, but at the same time improve immune reconstitution so that our patients don't suffer from infections long term. So the last study, this brings us to the last study, which is an abstract that was presented at the Best of Tandem 2025, and it's an important study by the Ohio State group from John Caputo and Hannah Cho, and it's an amazing study that just had 8 patients, and it was still selected for the Best of Tandem 2025 because we don't really know how to treat chronic GvHD that is very severe. So this study assessed Axatilimab in combination therapies with Rezurock or Jakafi in the real world data. So for the background, Axatilimab was approved for patients who were very refractory to most lines of therapy that we have available, like steroids, Jakafi, and belumosudil. So this group showed what their patients that had combination therapies are doing. And this is, now that Axatilimab is approved, this is how we are using it. So it's really hard for us to have a patient who has chronic GvHD that is moderate to severe, and it's very not responding to many lines of therapy. And now we're trying Axatilimab, and we're not just stopping the Jakafi or stopping the Rezurock. Most of us are actually starting, and then we're trying to figure out what to do with the other immunosuppression. So this study shows that most patients don't have an NIH response, which is important. NIH response criteria for chronic GvHD is very stringent, and most patients don't have. At most they have a partial response or a stable disease. Sorry, stable disease, not partial response. But if we actually look for symptomatic improvement, the addition of Axatilimab with one of the other combination therapies, 75% had a symptomatic response, and that's important. But it also shows us that the addition of more therapies is concerning for adverse events. And what are the adverse events of these patients? Infections. So 3 out of the 8 patients had significant bacterial infections with osteomyelitis. That's significant. And then viral infections was common. And this just brings us to show, to really assess how we're defining trials for chronic GvHD. We're not doing the best job. It's not easy, and that's the problem. It's not easy to design a trial for chronic GvHD patients because it's they flare, they get better, they flare, they get better. And the way that people are using these agents in the community is very diverse. Some patients start Axatilimab and they start taking out the first agent that the patients got into. Some patients are just stopping the last agent they were into. So how we treat chronic GvHD in the future still needs a lot of work. So this is why I chose the 3 studies, and it was more to say transplant is moving to a more precision medicine approach, but we still have a lot to figure out. It's not one transplant for all, but it's how we can assess how we do the transplant and look at prognostic factors and decrease GvHD and improve immune reconstitution.